Hello, good evening, everyone. Welcome to all my listeners and anyone who's listening, my colleagues, my friends, and my prospective patients. It's a pleasure to welcome you to another Facebook Live, and hopefully I can answer any of your questions that you may have. And I will go ahead and get started after a brief introduction. I am Dr. Shaher Khan. I'm a board-certified plastic surgeon. I have done, after medical school, 5 years of training in general surgery, where I'm a board-certified general surgeon, having done mastectomies along with all the many different aspects of general surgery. I did then 2 years of burns, where I did burns critical care training, did research on Integra artificial skin, then followed by 3 years of plastic surgery, where I basically did all aspects of plastic surgery, 3 years training. So that was 10 years after medical school. And now I'm very much honored to say that my practice is exclusively devoted to explant surgery, removal of implants, be it silicone and saline or residual capsules. And that this is essentially the focus and gist of my practice. I get asked this a lot as to how my practice moved towards this aspect. You know, for someone as a board certified plastic surgeon, I never augmented, and I did all cases except for breast surgery. And now my entire practice is strictly devoted to explant for someone who strongly, honorably believes in that the implants, be it saline and silicone, both hurt the body. They do not have a safe profile. It is breast augmentation with both saline and silicone, replete with problems, as you will see. And hopefully we can see not only from this discussion, but also from the many patients who are speaking in the masses. And I tell my patients and I tell my colleagues, my physician friends, don't listen to me, listen to the many patients, because your answers will clearly be available as to what the destructive nature of the breast implants are, and basically how it continues to basically be evading and tricking the many doctors who assess the many patients who have breast implants, and they are told that they essentially have all in their head and that they have other issues, but not the implants. Now, having said this, I will go ahead and kind of briefly go over what I believe in my mind, why augmentation is not a good idea. The first and foremost thing that I tell patients is breast implant illness is real. And what is breast implant illness? It is a constellation of signs, symptoms of breast implant illness that touch almost all aspects of the human body. Literally, if you look from the top down, from the hair follicles to the rashes, for example, on the face and the rest of the body, including problems with vision, which is specifically Sjogren's or dryness of the eyes, along with the many other problems that occur on the head, for example, migraines. You also have endocrine thyroid problems that occur, neck and back pain. You have trickling of the throat, for example, along with tinnitus that's ringing in the ears. You have sinus problems, sinus pressures, along with chest pain, difficulty breathing, shortness of breath, tachycardia. Just today, I talked to a patient of mine. She works in the health profession, and she was saying she used to have episodic episodes of heartbeat in the 140s, 150s, and believe it or not, she said that she's had only one episode post-explant. And this again attests to the many symptoms of breast implant illness. And this is where you have the GI issues, GI disturbances. There is a patient that came today from North Carolina. She cannot tolerate food, for example, and this is a lady that I'm going to operate tomorrow. You have patients with reproductive issues, premature menopause, rheumatological problems, which are the joint fibromyalgia type symptoms. You have tingling numbness in the arms and legs, along with plantar fasciitis, amongst the many, many, many others, as you will see, worsening of the psoriasis. You have psychiatric disturbances like depression. And this is what I tell everyone, you know, and going back to what the FDA has said, And again, if I may use them as an example, the FDA last year clearly highlighted the 3 warnings that all plastic surgeons who are potentially augmenting patients need to discuss actively and have them co-sign basically, and such that the discussion did occur between the plastic surgeon and the prospective patient. That number 1, the breast implants are not lifetime devices. They last in the body anywhere from 10 to 15 years. According to my experience, anywhere from 7 to 10. We have seen patients of mine, and I have done Facebook Lives with, that they started reacting 2 weeks into their augmentation. And there are some patients that start reacting almost 20, 30 years later. But there will come a time, on average, 10 to 15 years, according to the FDA, by my experience, 7 to 10 years before they start becoming reactive. The second thing that what was highlighted by the FDA was breast implants are associated with breast implant associated anaplastic large cell lymphoma, which is a direct cause and effect. Had the patient not had the implant, she would not have had the BIALCL, which is the lymphoma cancer caused by the implant itself. As a result, the textured implants were banned. And also they mentioned that smooth implants are also involved in causing lymphoma. And the third thing that the FDA highlighted was the fact that breast implant illness exists, and if the patients have these constellation and sign symptoms that I mentioned earlier, that these patients should seek medical attention and ultimately eventual removal. We also know, if you listen to the manufacturers, they themselves, if you go to my Facebook private breast implant illness support group page, you will see a mentor, for example, clearly says patients who have silicone implants at year 3 into their augmentation and every 2 years there onward should get MRIs to detect for silent rupture. And we also hear mentor clearly in their advertisement saying that the implications behind a rupture of a silicone implant are unknown. And this is very intriguing in the fact that how can these devices be implanted where the effect of the rupture, which is not known, and you would continue to put them in saying that they're safe and effective, which are the 2 adjectives that describe the implants, and where they're contradicting each statement, where they're saying they're safe, but at the same time they're cautioning you to get an MRI, which no one gets, and also that there is an entity called breast implant illness. Now, what I'm going to do is, given my practice, the whole gist and essence of the explant surgery is what? That the surgeon needs to be, in his or her mind, be truly committed into what is breast implant illness is real. How can a surgeon accept the fact that breast implant illness does not exist and then he or she go about removing the implant? Of course, if you do not define the problem, how can you solve the problem? So the first order of business is the surgeon must accept that breast implant illness is real, and they must vocally overall discuss how explantation is done. If you go to 10 different plastic surgeons, you will be surprised. You're going to easily get 10 different answers, and within their practice you will get 10 different variations of how they practice. For example, if someone is young and healthy, they're going to go ahead and offer them what would be a total capsulectomy or an end block. But if they are sick, for example, on Humira or an immunomodulator, strong medication, then they may say that the capsule can be left behind. Wrong. The entire bounce back, rebound, return to good health is truly dependent on the surgeon firmly believing that the entirety of the implant plus the capsule plus all inflamed tissue must be removed definitively, and that this capsule must be sent to pathology to rule out the BIALCL, and that any abnormal tissue must be removed, and cultures must be taken for aerobic, anaerobic, and fungal and sent to microbiology to put to rest that there is no mold, that there is no bacteria associated with the implants. And it is imperative that this be done, because if it's not tested, then we won't know what the problem was as to why the patient was hurting. As you will see just from the Facebook Live yesterday, there was a big mass on the left side that I removed, which was clinically consistent with what I would say is a lipoma. We'll see what the pathology says. Any abnormal masses that are encountered must be sent to pathology. Any abnormal fluid must be sent to cytology to rule out the breast implant associated anaplastic large cell lymphoma. And the point I'm trying to make here is, during the time of the surgery, all of the capsule and inflamed tissue must be removed, and this needs to be investigated, looked into by the pathologist, so we can say with confidence that this was not lymphoma and that this was not a bacterial infection. Sometimes the implants are associated with bacteria with an indolent infection, and it is important to rule that out. As you have seen, the FDA also highlighted that the number of BIALCL cases are underreported, and certainly they are, because no one is testing for them. So it is important to ask your plastic surgeon to test for this specifically, and there is a CD30 analysis that needs to be done. Also, if I may mention that as the implants last in the body, especially the silicone, the chance of rupture goes up significantly, especially after the 10-12 years. And as you will see, most of the studies, they stop at 10, 12, 13 years because they know as they follow the patients over a longer period of time, the rate of rupture will go up significantly. So the point here again is, it's better to take care of a small fire than a big fire, which basically means take care of the explantation. You don't want to have a rupture of the silicone implant and then be dealing with and tackling the problem later on when you have a lot of pain, discomfort, spillage into the lymph nodes like we have seen, and you don't want to be dealing with the aftermath of what is a rupture. You want to take care of this matter preemptively and sooner rather than later. Now, what I want to do is, in my practice as a board certified plastic surgeon, and 99% of my practice is exclusively devoted to explantation. I must say, there was a patient of mine that came to me on Monday, just 2 days ago, and he had a finger amputation. I reattached it, and I said those were the days when I was basically doing everything except for explantation. And now exclusively this is what I'm doing. Just this week alone, for example, if I may share my schedule, and then I'm going to request my audience to please ask me any questions, and I'll be more than happy to answer. So just this week alone, on Monday, I took care of a lady. She had pancreatic cancer, a Whipple procedure. She had a history of carcinoid, so I had to do her at the hospital on Monday, and she got the same surgery that I offer all my patients, which is entire removal of the implant capsule plus all inflamed tissue. So this was a case that I did at the hospital because this was not suitable for surgery at my surgery center. On Tuesday, today, I did a lady. She had residual capsule. So in 2010, she had her augmentation done. And then in 2020, she had removal of the implant, but the capsule was left behind. And in this case today, I actually did remove the residual capsule. 100% residual capsulectomy was done along with the capsule. And I ended up doing a lift on both the right and also on the left, a mastopexy, because this is a time where I felt I could do it safely. And she certainly did need it given her presentation. There's a patient of mine that I talked to yesterday. This is a nice lady that I'm actually going to be doing a Facebook Live, and I'm also going to be interviewing her. She had capsules removed one after another, a total of 10 surgeries. Yes, that is correct. 10 surgeries on the right side and 7 on the left, given the capsular contraction that she had. So since 1999, and we're going to do a Facebook Live with this nice, generous lady. She's going to share her experience with us. She was living through the many signs, symptoms of breast implant illness, and now, 14 weeks out, she tells me she has resolution of her almost all the signs, symptoms of breast implant illness, and that she has some discomfort, pain on the left side, but certainly much more manageable than what it was. And I anticipate over the next several months that this is only going to dampen, and she will have resolution of her regular feelings. So again, this goes to showing us that it is imperative, it is critical, important to not only remove the implant, but also the capsule and also the inflamed tissue in the proximity of that capsule, and that all of this tissue needs to be assessed and looked at by the pathologist. As I do the procedures, as you have heard me say, we basically I do it in a manner that is unique. I do 7 things pretty much consistently all the time in all of my cases. Number 1, I basically have not used drains in any of my saline explant patients, and in the vast majority of the patients, even with the many ruptured implants. And again, this goes to showing that if there was any frank spillage of the silicone into the chest, or residual silicone, or any inflammatory tissue left behind, this would mandate or necessitate the usage of drains. And I've been able to do the surgery essentially in a bloodless field, and I've been able to do the surgery in a manner where all of the inflamed tissue is removed and the need for the drain is not there. Certainly there have been some cases where a seroma did come up, but this is only a handful of cases, and they can always be aspirated. So the point here is the surgery can safely be done without the need for the drains, and I have a track record of patients who have not needed drains at all, and this absolutely can be done. The other thing is, I find in the many patients who have capsular contracture, or they are relatively young, and if the surgery is done in the manner that it can be, even in the many 40-year-old, 50-year-olds, that the lift is not always required. In the patient today that I did the mastopexy, the lift, she certainly did need it, and I could tell going into the surgery that she would benefit from the lift, and I offered it to her on my own, because I felt that the chance for nipple necrosis, skin necrosis was basically very reasonable compared to proceeding with the surgery and getting her off the OR table in a very timely fashion. I find that 80% of my patients do not need a lift at the time of explant, and this is why I don't offer it to them. And you do not want to do any unnecessary surgery. This is important. The third thing, I always test 100% of the time cultures for aerobic, anaerobic, and fungal. So this puts to rest the possibility that this could be mold. Now, there are three checks and balances, if you will, if this is mold or not. Number one, mold is very rare, but it does occur. As you will see, there is microbiology reports of patients that have had mold, and I've sent them to the infectious disease doctor, and they've been treated. Like one patient was treated for almost 8 months with antifungals because she was very much infected. Now, the three checks and balances, if you will, I have are: number one, I take the fungal culture, then I send to the microbiology lab. So they check and assess, and they do the stain in order to check for that. And they grow on a dish for 4 to 6 weeks before they conclude definitively that this is or this is not fungal culture. Number two, the pathologist, when they look under the microscope, if they see any hyphae of fungus or branch-like structures, then we know clearly that this would be a fungus, and the pathologist would alert me and the patient via the report that this is suggestive and consistent with mold. And then grossly, I can see if there's any black discoloration or problems, then we can tell. And this is where sending the capsule off to pathology is key. And this is the next point. I send 100% of the capsules to pathology so that we can rule out the BILCL. We can also assess and see the histiocytes, which are the inflammatory cells, the macrophages, the giant cells, the cleanup cells. We can see if there's silica, and you will see the many pathology reports that highlight the chronic inflammatory nature of the capsule, and that's why it's imperative to remove. If you look at the last pathology report, it said capsule has in it breast implant particles, and this is the gel bleed that occurs in both silicone patients and saline patients. The other thing that I do is 100% of the time, I return the implants to the patient, because the patient must see, visualize, and physically touch the implants such that they know that there is definitively psychological closure and closure, because these were the implants, and they can match it with their cards that they may have. I also take pictures and videos, high definition, of the chest, most importantly, showing all capsule was removed. This is the most important video, if you ask me, showing the chest that all capsules removed, and that there is also cutting open of the capsule on the table, and there is documentation via photography and still pictures, and also high definition video that clearly shows that the chest is free and void of the capsule, and that the cutting open of the capsule where the implant is removed once the patient is closed, such that there is basically a check and balance so that the patient is content and happy. The single most important thing, going back to, is the choice of the surgeon. If the surgeon does not want to open the accept BII exists, then I will have reservation about this doctor about accepting the fact that breast implant illness exists. And there is no shame or harm if the FDA can say that the breast implant illness exists, there is lymphoma, and then there is a 10-15 life-year span. The plastic surgeon should vocally gladly accept that it does exist. And there is, if anyone denies breast implant illness or they don't want to hear the word, which is unfortunately the case is in many of the plastic surgeons, then we need to question the validity of the surgeon into him or her doing the right operation. The whole surgery is dependent on the surgeon's commitment, faith, sincerity, that 100% belief from the heart that all capsule and all inflamed tissue must be removed, because this is what's dependent on the patient bouncing back. You don't want to go through the whole surgery like my patient from today, when she had her explant, and the next thing you know, she has to get a residual capsulectomy. You don't want to be in that situation. You have to have a surgeon that firmly and certainly believes. And nowadays in the social media world, you will see that there is a track record, there is a check and balance, not only on me, but all the other surgeons, so that the other patients who have undergone or gone through the surgery can validate, authenticate, certify that this is the same pathway that the next prospective patient. And this is what I find is most critical. Every patient should talk to the surgeons, all patients, so that they can gauge, see, and feel comfortable and confident into signing up with the surgeon. The other thing is you have to talk to the surgeon. Only the surgeon knows what happened in the OR. You cannot talk to any of my staff, and you cannot talk to any one of my team members and get an answer, because no one knows what happened in the operating room except for I. And it is so, I would say, complex and very much driven by the surgeon, that anything else that's given to the information to the patient is not going to be certifiable. The point I'm trying to make here is that some patients say, well, we talk to the surgeon's associate or the physician assistant. No, you have to talk to the surgeon, him or herself. You have to have that connection. You have to have that bond. You have to look at the surgeon in the eye, and the surgeon has to look at you in the eye and say, yes, I'm making that commitment, because it's all about that commitment. You don't want to be, well, I will do the best I can, or I did the best I can, or let me see what I can do. I will sincerely make the effort. But this is where, if you don't have that firm faith going into the operating room that you're going to remove it completely and definitively, it's not going to happen. Because when the going gets tough and the dissection off of the rib is being done, where the capsule is being removed, if the surgeon does not believe in it completely, definitively, he or she will then have second thoughts or doubts about doing what would be a relatively involved and, I would say, dangerous operation. So what I'm going to do next is I'm going to go ahead and talk about what I feel are, the 5 criteria. You probably have heard me say, but repetition is good. How do I know that a surgeon, or at least in my experience, that the surgeon did a job where it reaffirms that the surgery was done right? Number one, the length of time it takes for the surgery. For example, if your surgery is done in an hour, I can tell you with absolute confidence the capsule was not removed in its entirety definitively. I take almost 4 hours to book my patients. And this is the length of time it takes for me to doing the complete surgery, where complete 100% total capsule is removed. And this is where I say the 100-100-0 rule. 100% of the time, 100% of the capsule is removed, with 0% of the capsule remaining behind, and preferably in the en bloc fashion. Or the next level down, which is going to be the 100% total capsulectomy. And this is basically key, that the 4-hour length of time. The length of incision as well. I've heard one operative note that the surgeon removed the implant en bloc from the nipple areola incision, and that I will tell you that's virtually impossible, even if it's above the muscle, for example, because you have to be able to visualize and be able to dissect in a manner where you're going to remove everything and you're not going to potentially puncture. The third thing is you have to basically return the implants. You do not want to have, I saw a report by another patient, she went to another surgeon, and deflated implants were returned to the patient, and very likely they were punctured in an effort to remove them from what is a small incision. And that is the next point. The incision has to be, and this is the point I was trying to make earlier, the diameter of the implant essentially dictates the length of the incision. The next thing here is you have to have the videos and the photographs that certify that the surgery was done right. And the fifth thing, which I find is the most important, is the social media presence and discussions, and the overall reputation of the surgeon as to how well she's doing it. Today, in the world and age of marketing and social media, it doesn't take much to pay someone and to get validated by a group that may be interested in financial donations, and to get free advertisement, not free, but paid advertisement to promote a surgeon who may be up to no good, unfortunately. Now remember, end block surgery is not taught. This is something that is acquired, or a belief. If you go to any of these surgery centers where the training occurs, the only time the end block has been done, or total capsulectomy, is in those select patients where the lymphoma has certainly indeed been detected, and the textbooks and the medical surgical requirement is total removal of the capsule, because if any of the capsule is left behind, the lymphoma is left behind, and it is in those situations that the entire capsule is removed. No one can tell visually by looking at the capsule if it has what are precursors to the BILCL, and that's why it's imperative to send the capsule off. And we know clearly, just mentioned above and before, that those patients where the capsules were left behind and they underwent residual capsulectomy, those patients certainly did benefit from the explant surgery, not initially, and that the residual capsulectomy was then ultimately responsible from then bouncing back to a state of good health, minus the toxins that were present in the capsule and the periphery of the capsule in that inflamed tissue as well. Now, what I'm going to do is I'm going to go ahead and answer some of the questions that I see. Do you recommend lymphatic massage? So lymphatic massage is for those ladies that have had lymph nodes removed from their armpit area because of breast cancer, and now their arms might be swollen as a result. So they will certainly benefit from a lymphatic massage, lymphatic stockings, for example, and they're the ones who need that massage. Now, I ask all my patients post-op, approximately a week out, to massage their chest with aloe vera, cocoa butter, shea butter, vitamin E, or olive oil. And what that does is the dermal lymphatics, the lymphatics within the dermis, the skin, are nourished, and that helps soothe that skin that was inflamed. As you will see, that many patients have dilated veins on their chest as a direct result of the implant's proximity to the skin. And so it helps nourish that skin and return or normalizes the skin tone, if you will. The massage over the incision helps desensitize those nerve endings which were cut by the blade. It also causes nerves to come in an orderly fashion towards the surface. And as you will see, there are 4 layers of suture that I use. Primarily, that is 3-O-vicryl, which is dissolvable suture, and then stratifix suture. 2 or 3-O or 3 or 4-O, the stratifix suture. These are the 2 sutures that I use. They dissolve anywhere from 100 to 120 days, and that's why gentle massage in a circular fashion directly over the incision allows for normalization of the skin tone and also the sensation of the skin and nerves to the incision. And also, as you will see, it takes almost 12 months or so for the incisions to settle, and this is why massaging of the chest and also the incision, be it any incision for that matter, or any injury, for example, will allow for normalization of the skin. The next question, so I'm going to go ahead and please ask me questions and I'll answer all of them. You know, I'm not like a computer savvy, Facebook savvy. I see some questions here and there, and now I'm going to answer each one of them to the best of my ability. I am going to, when can you sleep on your stomach? Now remember, when we sleep on our stomach, your arms are always stretched out. Now I want you to see the anatomy. That the pectoralis muscle sits on the chest and it inserts into the upper arm right here. So when you stretch your arm, you're going to find that this pectoralis muscle is going to get stretched, and we don't want that to happen. Now, this is the principle of plastic surgery. You got a tummy tuck, you have to wear a garment that goes from your thigh all the way up for 6 weeks at least. You get a thigh lift, you have to wear the garment for 6 weeks at least. You get a brachioplasty, which is an upper arm lift, same thing. So the same thing, you have a explantation, you want to go ahead and wear the bra and the binder for a 6-week process that will help with the recoiling of the skin and the breast tissue, and also that dead space where the implant was sitting. It will help normalize that such that there is compression and recoil, and that swelling that occurs is addressed very definitively, and it allows for optimal wound healing, just like it does after a tummy tuck. Why do some women have more trouble with hematomas and arceromas, and does having drains make a difference? So, number one, drains do not prevent a hematoma. I'm going to say it again. Drains do not prevent a hematoma. A hematoma is a collection of blood that forms under high pressure arterial primarily, which is a technical issue 24 to 48 hours after primarily, which is a surgeon problem, a technical problem. There are patients, for example, three of my patients, one of them stretched at 6 a.m. in the morning, and then all of a sudden she had what was a filling up of the chest because of the stretch. This is where the and then again, I would probably have done the same when you're sleeping. The point I'm trying to make is another patient of mine, day 11 at a farmer's market, she was lifting something heavy, and that was a direct quote where the patient said, "I overly exerted myself." Another patient, day 9, overexertion led directly into basically what was a hematoma, and this would not have been prevented by a drain, because remember, the blood clots and it's not going to drain into the drain. So the drains are not required. I have a track record of hundreds and literally all these patients who have not needed the drains. Now, in my mind, if I find that the 800cc implant on the patient on steroids will need one, I'll put one in, because I can always remove the drain, but it is not required. Absolutely, it's not required, and convincingly it's not required. And again, in my practice, I have not put in drains for the last 2.5 years. And this is on the record, I've said this before, because the drain is not required and I'm able to remove all of the inflamed tissue. The hematoma primer, if it occurs within the first 24 hours, so one of my patients had a problem and I take full responsibility. This is a patient had a hematoma and I had to operate and drain this. Now, this is very rare. This is one patient that I've had. The other 3 patients have had the hematoma. It occurred day 9, day 11, and day 14. After surgery, and this is when the drains would have been removed. So the drains do not prevent a hematoma, and the drains are not required for the surgery. If you look at, and this is the homework that I tell you, please look at any of my YouTube videos, any of my videos where I'm dissecting. It is essentially a bloodless field. On average, my blood loss is 5 cc's each side, a total of 10 cc's, almost 10 drops of blood. And I'm happy to report that I've been able to do the surgeries in the manner that I have been. What is your opinion on breast implant illness? Now, 100% breast implant illness exists. Now, someone asked me this. There was a group that came from California, interviewed me, videotaped me, and did like a press release, and they asked me what percent of the patients get breast implant illness, and I'll tell you, 100% of them will get breast implant illness. It is a matter of time only. Because remember, the rupture can occur. I have had patients, look, almost 2 months ago, I did a Facebook Live with a lady from Texas. She had a rupture of these gummy bears 3.5 years into her augmentation. Now, don't listen to me, listen to her. There is no guarantee that someone will have a rupture. Look at the Mentor itself. The Mentor company itself tells us in their advertisement at year 3 of augmentation and every 2 years they're onward, MRI is recommended without contrast to look for a silent rupture. They're telling you it could rupture next year, it could rupture tomorrow, it could rupture 5 years from now. I did a Facebook Live from the operating room, a lady from 1990, 32 years ago. This was 2 weeks ago. You can see that. One side was ruptured, the other side was not. Again, I did not know this going into, but I assumed both of them would be ruptured because of the length of time. Why the other one did not rupture, I said good for her. But again, this was done in an unblocked fashion, and I was able to give her the exact perfect surgery such that there was no spillage of silicone. So the point here is breast implant illness absolutely exists, and once the implant ruptures, don't tell me if the implant ruptures, the silicone is not going to migrate to the lymph nodes. If the implant ruptures, it's going to migrate to the periphery. And once the silicone goes into the body, it will migrate into the periphery. Silicone inside the body, free floating, is only going to lead to a higher concentration of silicone in the periphery and eventually in the bloodstream, as we have heard Dr. Atul Mehta from the Cleveland Clinic, who was my guest, that it will only hurt. We have seen Dr. Henry Dykman, who did biopsies of the patients who had a rupture. This one lady, she, God bless her soul, passed away, and she donated her body to science, and biopsies were done of the spleen and nerve and other tissues, only to conclude that indeed there was silicone present in the many different tissues at different concentrations all over the body. We have Dr. Atul Mehta from the Cleveland Clinic. He published a report of a patient who had ground glass opacities within a CT scan of the lung that showed silica within the lung tissue itself that migrated from intact sealing implants from the chest via bloodstream and deposited into the lungs. These are clear reports published and discussed. If you go to my private breast implant illness Facebook support group page, you will see all of these discussions with these two doctors, which is concrete, hard evidence. And this is consistent with Brady's breast implant illness. Should all the capsules be sent for the lab? Absolutely. I will say there are some parts of the capsules that are thin, some parts are very thick. So they need to be assessed and looked at by the pathologist so that they can do the respective staining. We don't want to send a small 1 centimeter or a small piece of the capsule. Send the whole capsule so the pathologist can look at it. It's just like saying you do a mastectomy, breast cancer case, right? And you remove the breast tissue and you send part of it off for analysis for breast cancer in a patient who had, let's say, a prophylactic mastectomy. No, you send the whole thing and the pathologist will cut, dissect, and stain at different slides, different aspects. So we look at the whole thing. Why should you not look at the whole thing? Because some aspects of it might show what might be relatively thin, and some aspects relatively thicker, and this is where a complete analysis needs to be done. My next question, my right side has healed great with no pain and or tightness to date at 12 weeks, but my left side swells up a couple times a week out of nowhere. Does the brain work in such a way from left? No, this is where, remember, anytime you have an explant, and especially this is inflamed tissue, it takes 9 months to a year for the tissue to settle. This is where the gentle massage to the whole area is important, and then you continue to gentle exercise and giving it some more time. Remember, someone has grade 4 contracture. You cannot expect 2 or 4, 6 weeks later, or in this case 12 weeks later, everything to normalize. Even after a tummy tuck, it takes 9 months or a year or so for the tissues to settle. So we have to wait, we have to continue to do the massage, and we have to let time heal that tissue, that area that was inflamed. So it takes time for it to settle. How long does it take for the pathology test to get the results? On average, 3 to 5 days. I remember one winter break, they sat on the pathology report for 3 weeks, and they actually even called me, and I had the pathology send the report to the Mayo Clinic, an outside hospital, to look for, which is not uncommon. It is, if a pathologist is not sure, then they have their colleagues and another sister institution look at it. So on average, 3 to 5 business days for the pathology report to come. Sometimes they take a little bit longer to stain and look, but it comes by relatively fast. Next question. I'm looking at the questions here. Okay, so I see a question by Marianne, and we all know this is right there. December will be 3 years since explant, and I continue to have pain, tightness, pinching, constant pressure from my collarbone to my diaphragm, as well as seromas. My doctor will not drain the seromas. What can I do? So anytime there is a fluid collection, it needs to be assessed because it's abnormal. It's abnormal to have seroma. Seroma is a fluid collection which is more serosanguinous, non-bloody, that is a pocket of fluid that needs to be assessed. Now, the first order of business here is, did your surgeon initially send the capsules off or any abnormal fluid or masses to pathology? Because if we have that information, that gives us peace of mind that these seromas are likely not related to lymphoma. Now remember, you have to be thinking lymphoma, lymphoma, lymphoma. If you're not, then you're going to miss it, right? The eyes don't see what the mind doesn't know. Now, the doctor, first of all, we have to see, 3 years is a long time. Any seroma of the body should be removed, aspirated at a breast center, and it needs to be checked for the CD30 analysis, especially if it was not checked initially. The capsule that forms around that seroma needs to also be looked at. Very likely, and again, I do not know, and with all due respect, the question becomes, was all of the capsule removed or not? That's the single most important question. Number two, what does the ultrasound show as the consistency of that fluid? And very likely you can go to a breast center or interventional radiology where they can, under ultrasound guidance, your surgeon does not have to, they can put a needle into the breast tissue and pull that fluid out, and then send it off for CD30 analysis, send it, rule out lymphoma, BIALCL, rule out the microbiology, aerobic, anaerobic, and fungal, just to be complete, just so that you have ruled out an indolent infection, for example. And that also needs to be sent to pathology if that wall of that seroma can be sent definitively, depending on how and what size. Now, these are small pockets. If now 3 years out, you may want to get it removed. Any mass of the body, specifically the chest on a lady, needs to be ruled out for cancer, God forbid, because 1 out of 8 or 9 women are going to get breast cancer. There are other types of breast cancer in women, mucinous cyst adenocarcinoma, for example, right? This is a cystic type. We need to have a breast center weigh in and follow and make sure that these are addressed. What are the imaging features? Maybe as an MRI required. But your surgeon must be very much on board into also working with the interventional team or the breast center into working up these masses. We don't want to potentially, and I'm not trying to scare you, we want to be complete. I like to be complete. We want to think the worst so that we don't potentially miss something that might arise. Who knows, this might be a new mass, right? And it started 2 years ago or 1 year after the surgery, right? And we want to make sure that this is not potentially breast cancer. And if this is a seroma, what is the location? If there are residual capsules. So a lot of questions need to be answered. If the entire capsule was removed, I would be very much interested in knowing what the operative note and what the surgeon believed. No one goes out of their way into removing the entire capsule because it is a very tedious, very sophisticated surgery, and it is not easy surgery. If you ask 100 surgeons to remove the entire capsule off of the rib, I will say with confidence, at least anecdotally from my interaction with the many other plastic surgeons, 90 of them will question the fact that there is no indication to removing the capsule. They will say 3 things. Number 1, the capsule will likely dissolve, so leave it alone. Number 2, you don't want to do this risky procedure and potentially puncture the lung and get a pneumothorax. And number 3, no one has shown there is a firm belief by the plastic surgeons that capsules are not the culprit. Just remove the implant and leave the capsule behind, or just bovie it. That is good enough for the patient to bounce back. And I say absolutely not. The entire capsule must physically be removed off of the rib. And when I say this, if you can imagine, you're going to the store and you look at ribs, you can actually peel off that layer of that fascia of the intercostal, the periosteum and the perichondrium, which is the layer directly on top of the rib. that physically needs to be removed, bovied off of the rib for the entirety of the implant capsule and the interface of the intercostal fascia, the periosteum, perichondrium, the fascia of the serratus anterior, the fascia of the pectoralis minor. All of that needs to be removed along with the capsule for what is a definitive 100% total capsulectomy or en bloc removal, one of the two. So it is important to remove that all completely. It is not sufficient to cauterize or burn the capsule on the rib, because what happens is, as you can imagine, on the 4th of July, for example, when you're doing the barbecue, or even if you burn the tissue, for example, right, it's black, you still have remnants of what is silica and the silicon toxicity that's present within the tissue, and it's not physically removed, and that will continue in itself, even in the small quantities, to hurt the patient. Now, the next question I have here is, there is a podcast I did with a nice patient of mine off my chest. I'm going to go ahead and I actually did post it yesterday. So please go ahead and be on the lookout for that. I want you to go ahead and go into my Facebook page. I'm going to go ahead and look and see if I can answer any of the other questions that anyone may have. Now, one question that I just saw was, how long does it take for the body to normalize? Now, remember, if you look at breast implant illness, it doesn't come on like right away. Remember, I did a Facebook live with a patient, 22 years of age. 2 weeks into her augmentation, she had the many signs symptoms. She had basically intolerance and severe nausea. And once she got the explantation, she normalized. The point I'm trying to make here is that the vast majority of the times, you could have an early onset where you have breast implant illness. The many patients that I've talked to just recently, 3-4 years into their augmentation, they have the many signs symptoms. But on average, it takes some time for the patients to basically start exhibiting the many signs symptoms. And it is that questionnaire that I ask the patients to check off so that they can assess the severity. Yes, we don't have any lab diagnosis. We don't have any imaging diagnosis, but that questionnaire kind of gives us the highlight, that brain fog or the fatigue and the Sjogren's amongst the many other signs and symptoms, the 55 symptoms. That gives me an assessment as to how and what the severity of the problem is. And that same questionnaire can be used 1 month, 3 months, 6 months. Now remember, it takes almost a year or so for the body to equilibrate and normalize. I get this question asked a lot. So I did a case, where the patient was asking, what can I do to maximize my preparation for the surgery? Should I eat better? I say eat organic, eat healthy, fruits and vegetables. Processed meats are out. For example, hot dog or smoked meat or any of this non-organic growth hormone, estrogen infested meat, that is all bad. Eating organic, healthy. Eating an orange a day. You don't need to supplement with vitamin C if you're postmenopausal. Getting the vitamin D, B12, calcium levels checked, making sure, and remember, the numbers are low in the blood, then you can supplement them. But taking herbals only if you need to. It is absolutely required for the patients. If they're thinking of getting pregnant, the prenatal vitamins are key. But the point here is, there is nothing that you can do, exercise, for example, or taking another supplement or getting IV infusions of vitamin C. None of that is required. Just eating a regular healthy diet is all one needs in order to prepare. Read up on the questions, anticipate the compliance. Again, leaving the bra and the binder on, compliance with what is the T-Rex arms, limited movement, just wrist and elbow is not moved, but the wrist movement is basically key. For example, if someone has surgery today, they could very well brush their teeth because that's wrist function. They could type, text, they could make themselves a cup of coffee, but anything that requires reaching for the upper cabinet or lifting something heavy like a laundry basket or vacuuming is all out, because that is all pectoralis function. If you have had surgery on the chest, we don't want to cause shear forces on the tissue such that it will deter the healing process. The other thing I get asked this a lot is, what can I do to detox after? Now, I will tell you, things like charcoal. They're meant for patients who ingest, for example, aspirin or any tablets, so that the charcoal can bind. Infrared sauna, total not required waste. There is no supplementation of a pill or any basically regimen that one can do. Just eating healthy fruits, vegetables, the antioxidant food, for example, turmeric is good, that has been shown. But other than that, there's really nothing. The best detox is for the surgeon to removing all of the implant capsule plus that inflamed tissue, because that is all what the patient needs. Now, sometimes you have what may be silicone in the periphery or in the lymph nodes that might linger on, but over the next few months, or year, hopefully that will equilibrate and the body in itself will address, depending on the severity of the silicone toxicity. In some patients, as you will see, between the same patient, one side may show chronic inflammation, the other side may show no reaction, for example. So it's very interesting to note how the pathologists have read the many reports that I've put forth in my private breast implant illness support group page. Now, please ask me any questions. Now, what I'm trying to do here is I exclusively am focused on explantation. The goal here is to share with you what I see and learn and hear from one patient to another. And, all what one needs to do is, and I tell them, don't listen to me, listen to the many patients, and you'll get all your answers from them. Let me go ahead and see if there's any questions. So I explanted just under 2 years with another surgeon. I have free silicone still in one breast and lumps as well. Should I now get this out of me? Now, I will tell you, to have free floating silicone in the chest, it is abnormal, it can be painful, and it is reactionary, because we see this in the many pathology reports, right? Free floating silicone within the chest. One thing I would recommend is, and again, going to your plastic surgeon who can get an MRI with and without contrast. So these pockets of silicone or silicone granulomas, if you will, can be identified, so we know where they are. Sometimes what happens is the silicone is very dense, it tends to sediment down, and it can loculate and basically hide in these pockets of silicone. So once those are identified, my suggestion is that your surgeon go in and physically remove each and every one by visualization, by palpation, and also by the MRI guiding the surgeon, so that all of this inflammatory tissue is removed, such that the patient is free and void of this. Now, sometimes when you have silicone free floating within the chest, you have the lymph nodes that are draining the chest. They may have silicone in them, but at least the goal here initially is to remove that silicone granulomas, so that at least there is no pain. And the silicone in the lymph nodes, I wouldn't recommend removing them, because you touch those lymph nodes and a lot of them might be basically infiltrated with the silicone. You might get the silicone out, but the lymph node basin might be disturbed, and you might get lymphedema, which is swelling of the arm as a result. So, again, hopefully there is an antidote that comes that will leach, bind, basically. Dr. Atul Mehta said that he did offer his patient plasmapheresis, which basically means cleansing of the plasma via a machine that very much in a similar fashion cleanses the basically blood in dialysis patients, for example. And again, I do not know much. That's not my area of expertise, but this is something where the toxicology / hopefully the manufacturers themselves come forth with a way to manage and tackle this effectively. Now, the next question that I'm seeing is, I have 23-year-old under the muscle implants. What do you expect my implants will be like? Now, one thing that you can do is, it's hard to tell what they're going to be like, because sometimes under the muscle there is muscle, breast tissue, and then skin that is kind of camouflaging the real exam. Sometimes the only way you find out is getting an MRI without contrast to look for silicone rupture, which is what they call Linguini sign. And even there was a day where I did 2 patients back to back. One patient had an MRI that said rupture on the right, and lo and behold, it was intact implant. And the second patient said it was an intact implant on the right, and lo and behold, it was a rupture. So the MRI can be wrong, but the MRI is without contrast is the best modality that will highlight if this is ruptured or not. And the point here is only when the surgery is done and the surgeon is dissecting and he or she cuts open the capsule on the table, that's when you truly definitively find out if the implant is ruptured or not. And this is why every surgeon needs to approach every single case as if it's ruptured, because you don't want to be finding out while you're doing the surgery on the patient's chest that this is indeed ruptured and now there is frank spillage of the silicone. And if that happens, automatically a drain is mandated because the silicone is very caustic. So it says, so my suggestion is getting an MRI, so that way at least you have some information that will help guide you. If there is majority of the saline implants, if they're ruptured, they're going to be like a water balloon, like, completely deflated. They do not deflate slowly. Unlike silicone, if there's a leak, it is usually contained, and because it is relatively viscous, it does not travel. It is still contained by what is the capsule, and the capsule can get hardened as a secondary result. So I would suggest, if you're curious, getting the MRI, but ultimately, why wait for it to rupture? Get it out before it ruptures. Take care of a small fire versus a big fire, because once it ruptures, then you definitely have a lot more coat, microscopic spillage in the periphery, and that is much more difficult to handle. Unfortunately, this is no insurance is going to cover. So this is a very important point. The insurance reimbursement is shabby. It is horrible. It is not consistent with someone who will be able to do it in private practice, or even at a hospital setting if they're employed, because number one, the insurance says, who told you to remove the capsule? That's not the standard of care. And even when they do reimburse, you're looking at anywhere from $800, $1,200, $1,500, which will not justify a 4-hour operation, and the hospital will lose money because of the reimbursement. And so the point here is that anyone who takes insurance to do a case will 100% compromise on the end block or a total capsulectomy and will not do the operation sincerely, because it will not justify the financial reimbursement. This will be a Chapter 11 waiting to happen for that plastic surgeon. Unfortunately, this is surgery that majority of the insurance don't want to even recognize, don't want to even think about. They have their criteria of grade 3, grade 4 contracture or rupture before they even pay, and if they do, it is a very partial minimal reimbursement. Next question is, what will you do different with bottoming out implants? So what I have done is, as you will see, this is very important. If you look at the pectoralis muscle, the origin is on the sternum, the mid part. The insertion is on the humerus, and the implant is usually placed underneath the muscle by a good, reputable surgeon majority of the times. And as you will see, when the implant is put below the muscle, what happens with time, the implant only gravitates down and out, especially when the patient flexes and contracts the pectoralis. So what happens is, making the implant only bottoms out and lateralizes, goes to the side. So what I have done lately, as you will see in the Facebook Lives, I cut out what would be a boomerang type of a incision that allows for me to remove that excess skin, especially at the lateral aspect, and also tissue underneath where the bottoming out is occurring. And what it allows, and the way I place the suture it allows for what is a pseudo lift, if you will. Now remember, I'm not dissecting around the nipple areola, but it allows for the breast tissue to recoil with that excess tissue. It addresses the lateralized tissue and the bottoming out, and helps with the overall aesthetic result. And the select patients that I find where I'm able to do that on both the sides. So I have had a lot of Canadian patients. They certainly are able to come see me in person. Now this is what I want. This is part of the informed consent. You know, the many out-of-town patients that I see physically come see me on a Monday, do a phone consultation with me so I can assess and talk to you. As you will see, we'll be able to get into a lot of detail. Now once that has happened, you physically come see me on the, let's say the surgery is done on a Tuesday or a Wednesday, or let's say in this case a Tuesday. I see you in my clinic on a Monday. Tuesday you get the surgery. Tuesday, Wednesday, Thursday, Friday you recover, and then Friday morning, once I've seen you in clinic, you can certainly then plan on heading back to your hometown. This is usually, I've done it, for example, Thursday, tomorrow's patient, you know, there's a patient that came from out of town. I saw her today after my cases. And then she's all set, pre-op ready, informed consent has been obtained. She and I have talked at great length on the phone. I answered all her questions today. She's going to get her surgery tomorrow, and then early next week she's going to see me before she heads back. And as you will see, a lot of healing has occurred in the 3-4 days post-op, 5 days, depending on the time when I have seen you in clinic to the time I've had the surgery, and the patients I'm able to manage once they're back home. There are some patients, for example, that are from Chicago. I tell them go back home, like one patient today did, and so she's going to come see me you know, in a few days so that she can recover in her home, own home, rather than staying here in Michigan. So how long do I need to quit smoking? So 6 weeks is what the textbook says. Remember, you benefit from smoking cessation from the moment, the second you quit. Smoking slows down the wound healing. It constricts the skin and can cause wound dehiscence, infection, necrosis of the skin, especially in patients who have very thin flaps. So for that reason, 6 weeks is the optimal time for the patients to stop smoking. Very important question. Please talk, you know, this, my patients, this website, this Facebook page was developed by my patient from Arizona. So she's the mastermind behind this. This has helped a lot of other patients, prospective patients. They talk to my old patients. That way you feel comfortable and you know exactly what is going to happen, so there's no surprises. Most of my patients are actually very excited about proceeding with surgery because they know their good health only awaits them. They're certainly nervous, as all patients are, but they're certainly very excited for the surgery. Please, you know, I just asked, where are you located? Please go to Shaher Khan, MD, Novi, Michigan, executive plastic surgery, and you should be able to Google. See me on Facebook. This is where I would say like 90% of the information is. You know, we're trying to put information on TikTok and Instagram. Again, I'm not a social media person. My team does that, and so hopefully, you know, you're able to get the information. YouTube is also a very good resource where you can see the videos of the dissection itself. Next question from Anne. Should I be checked for BIALCL 2 years post-explant of ruptured implant, as I have ALK phos level and low platelets and various other symptoms, or a connective tissue disorder? Also still have silicone in breast tissue. You know, the inflammation, the silicone toxicity that continues to hurt and stimulate the immune cells of the body are ultimately what are responsible for that. What is the PLLC? These are reactionary tissues, especially in the textured implants, right? Had the patient not had the silicone, the textured, for example, they would not have had the lymphoma. There is a direct association between, let's say, textured implants and lymphoma. That's why the ban on the textured implants. Now, if you have residual silicone in breast tissue and you have these irregularities of the lab, first, you go see a good internist, a hepatologist, someone who specializes in the liver. I would recommend, it is not healthy. It is not normal, and it can only be painful for patients to have silicone free floating within their chest, and to getting it out, it would be a reasonable, wise option. I have had patients that I've managed to had buttock injection of silicone. Again, malpractice done by non-medical professionals, even, believe it or not, medical MDs who are done this in places like Florida, New York. You hear about it from time to time in the news. These patients complain of buttock pain when they sit down, and constant pain even lying down, putting pressure. Even at rest, they feel like there are, quote, worm type sensation. Worms, i.e. That are kind of migrating up and down the legs. This is the reactionary inflamed tissue. It is, as you can imagine, not healthy to have free-floating silicone inside. This is my personal analysis, because if you look at the pathology reports, you see the chronic inflammatory nature of the capsule in the periphery of what are intact saline implants, and certainly ruptured silicone implants as well. So I have a question from, I am 4 years post-mastectomy with implants. I am tender and sore around my implants, and when I move, sometimes it feels like a raw sore. Is this part of BII? Now remember, this is the inflammatory nature of the implants. If you likely look at your chest, you have dilated veins, you have reactionary tissue. This is the silicone mastitis that we have seen some of the pathology reports. This is your body's trying to tell you that I'm hurting because of the proximity of the implants. Now, I'm not trying to scare you. One of the differentials is you could potentially be ruptured, right? This is according to the Mentor. If you have silicone implants, that's what I'm assuming. According to the Mentor website and the recommendations by the manufacturers, at year 3, you should get an MRI without contrast to look for what is a potential rupture. Now, this is where pain, inflammatory nature, you could have a capsular contracture, you could have had pressure on the nerve in the proximity of the chest, where you have the nerves that feed the nipple areola complex. So there are many reasons you should get a physical exam. Now sometimes, there are other modalities where the surgeon may place the patient on medication that helps break down the capsular contracture, for example, or they may give a steroid shot in the periphery of what may be scar tissue. Just again, the ultimate treatment here is, removal of what may be scar tissue that you may have. Now, when someone says, is this part of BII? I always ask myself, go to that questionnaire, and if you call my office, or you can go to my website, we'll have that up as well, where you can see the many signs, symptoms of breast implant illness. And just if you look at the questionnaire, brain fog, fatigue, chronic neck and back pain, dryness of the eyes, you have weight gain, autoimmune issues, endocrine issues, vertigo, chest pain, discomfort, fibromyalgia type symptoms, depression, anxiety, rashes, digestive issues, intolerance to food, throat clearing problems. You have hair loss, where you have alopecia, where your patients start losing hair. You have the many signs, symptoms, 55 of those on that questionnaire. Now, if someone is young and healthy, let's say the 25-year-old, and she's checked off, let's say 20, 30, sometimes even 40, then we can say with certainty, look, She's gone to the doctor. She doesn't have lupus, Lyme disease. She doesn't have rheumatoid arthritis. She doesn't have diabetes, high blood pressure, or any problems. She's not ill, but then she has all these many different organ systems affected. And if the other medical problems like lupus, diabetes, all of them have been ruled out, then there becomes more and more of a pointing towards breast implant illness. So it is not uncommon for me to ask my patients, how many of those symptoms on the questionnaire did you check off? And if they say, well, I am 100% sure I have BII, and I say to you, I have not seen you, but all what you're saying is strongly suggestive of BII. And once the surgery is done right, which means removal of the entire implant capsule plus all inflamed tissue, then we know with definitive certainty post-op that this is what's going to lead, very likely, hopefully, no guarantees, in what would be resolution of the many symptoms of BII. Now, one of the problems with breast implant illness is chest pain soreness, because you have the nerves in the proximity of the implant that may be irritated, inflamed, that might have radiated pain, let's say, to the rest of the chest, or maybe from capsular contracture, grade 4. That in itself will cause it. If you look at my Facebook Live that I did from the operating room yesterday, where the implant literally was poking out on the left side laterally towards the outside and towards the inside medially, that in itself will account to chest pain as a result of the grade 4 contracture. And the indication there is, if you ask me, removal of the implant, because you know that lady yesterday, she had a rupture of saline implant in 2015. In 2014, she had saline implants. 2015, she had a rupture on the left side by capsular contracture. And then, like I mentioned in my Facebook Live, she had a replacement on the left side, and that ruptured again. And then 2017 was her third set, and this is where you see the severe contracture. And the golden point here is, you see the questionnaire, and you want to go to your plastic surgeon to see what he or she can do in order to help with your signs, symptoms. If you have capsular contracture, what can be done to manage it? Sometimes they can break the capsule such that it relieves this pressure as a result of that capsule that can be broken, or a capsulotomy can be done. As some surgeons have actually done that. They physically go and score by opening up surgically that capsule, or sometimes they remove the capsule and they have put in alloderm or other cadaveric tissue in the chest, or they might just position this in a different location. Let's say if the capsular contracture occurred above the muscle, they can certainly put below the muscle to help. And again, the answer here for me is implants are not safe, and I'll go ahead and conclude with this. Implants are only replete with problems. No one walks into my clinic and says my implants are making me run better, breathe better, I'm able to take nice deep breaths. The implants only rupture with time. They're associated with lymphoma. They're associated with the many signs and symptoms of breast implant illness. Eventually, all patients will succumb to breast implant illness, because one day the implant will rupture. It's not meant to be in the body forever, like the FDA said, 10 to 15 years. And once it does rupture, there is going to be, everything is going to go haywire. The symptoms usually go worsen. And then what happens is, then you're doing damage control, taken care of. And I'm not trying to scare you. This is what the manufacturers are telling you, right? Get a MRI at year 3, and every 2 years they're onward. That's exactly their point. And this is where the FDA clearly mentions, if you're having symptoms of breast implant illness, you know, that I highlighted earlier, that you can see in the questionnaire, then you go seek attention of a good board certified plastic surgeon who believes in breast implant illness, and who genuinely will go out of his or her way to give you the relief that you very much need. The implants also obscure what would be a good physical exam. Remember, the number one reason how breast cancer is picked up is by a good physical exam monthly. And 1 out of 8 or 9 women in the US are going to get breast cancer. And we don't want to obscure that exam by what may be a capsular contracture, or ladies not want to get a mammogram. And there are infections / capsular contracture, asymmetry, bottoming out, lateralization, rupture, amongst the many other problems, including lymphoma, that are known to be associated with implants. These are not safe devices. Again, it astonishes me that, given what we know, and especially after the warning, the implants continue to be given that safety profile, which is absolutely not the case. They should be banned, and they should be permanently banned, and there needs to be a swift resolution by the Department of Health along with the manufacturers so that we can provide relief to the many who certainly do need it in a very timely fashion before more problems arise, more pain and misery that the patients have to live with. And it's not only the patients, but it's also the significant others, the husbands, the kids, the whole family and the whole system suffers. And it is not fair for the patients to be given the runaround, especially after textured implants. There was no recall. They were just alerted by the FDA did mention to Allergan that you need to alert your patients who got the textured implants that they have a device in them that is associated and that is banned. They did not tell them to get them unless you have problems. They were never told that all of them can certainly get them removed and they will be covered by insurance, for example. And the point I'm trying to make here is these are not safe devices, and hopefully there is legislation that's passed in the ICD-10 code so that there is coverage for the many patients who cannot afford to get this operation done in a very nice, viable, safe way. And the worst thing that I will say to you is what happened to my patient today, for example. She got her explant surgery. Now she had to undergo a second surgery to get the residual capsules because her surgeon did not believe in a total capsulectomy or an en bloc, because still to this day, the vast majority of the plastic surgeons do not believe in breast implant illness, which is unfortunate. Now, what I'm going to do is hopefully I've answered the questions to the best of my ability, and you found this informative. There needs to be a rapid discussion. When I use the word rapid, not like 5 years, 10 years later, but there needs to be a consensus. There needs to be an agreement, actively, so that we can discuss this not only with the patients, but the many family medicine doctors, primary care doctors. Just within the last 2 weeks, I've had 2 patients. One of them, her OBGYN doctor referred the patient to me and said, you need to get your implants out. There's another primary care doctor who sent the patient over and referred the patient to me so that she could get her implants out. Now, this is a change for the better. It's coming at a very slow pace, but this needs to be actively discussed at the many medical conferences, journals, so that we can teach the many other doctors who provide care to the millions, so that they are aware that this entity indeed does exist. There is indeed an FDA warning, and that there is a real problem and that there is a real solution. Now, one thing I'm going to end on an optimistic note. When the surgery is done right, vast majority of the patients, you're looking at 85-90% of the patients anecdotally benefit, improve from this surgery. This is not a surgery where you're looking at half-half. Vast majority, if you look at the publication out of Utah, for example, this was done almost 9 months ago or so. They reported, almost 90% of the patients sought benefit from removal of their implants, and that in itself speaks volumes. Having said this, it was a pleasure to be here. Hopefully you found this informative. Please share. Please listen to the podcast that I posted yesterday. Hopefully you found that informative. Please discuss, talk. Hopefully you can share this with the many other patients who have explanted so you can learn from them. There are patients that come to me that have their books that are this thick. They have taken notes. They have, studied this phenomenon. And I will say they are so well read and so knowledgeable about what is a real problem. So having said this, have a good night. Take care and all the very best.